To open the next session, please welcome Professor Choo Pin, Asian Oncology Society Board Member and President of the Singapore Society of Oncology.
Good evening, ladies and gentlemen. Welcome to the session on the changing landscape of hepatobiliary as well as pancreatic cancers. It is with great pleasure that I invite Professor Choi Minsig, who is a director of GI Oncology at the Stony Brook Cancer Center. He is an expert in gastrointestinal cancers as well as translational oncology, and he's here to share his expertise with us. Welcome, Dr. Choi.
Magandang gabi po sa inyong lahat. This is Dr. Choi Minsig. I'm a medical oncologist at the Academic Medical Center at the Stony Brook University Cancer Center. I specialize in GI medical oncology for the last 18 years. Actually, I'm from the Philippines. I was a medical graduate of the Far Eastern University back in 1998. And after my medical school, came to US for my residency in Chicago Medical School and my fellowship at Wayne State University. And I've been a medical director of the outpatient oncology and GI medical oncology at the Stony Brook Cancer Center for the last 6-7 years. And I would like to thank Dr. Fernando, the chairperson for the 2020 Asian Oncology Society, for inviting me, and Dr. Gloria Luna and Dr. Fernando for all this arrangement. Good evening, and thank you to the Asian Oncology Society for inviting me to talk about changing landscape of hepatobiliary and pancreatic cancer. My name is Minsig Choi, and I'm at Long Island, New York, and I'm sure this is evening, and you know that there is about 12-hour time difference in Manila and New York. Before I start my lecture, these are some of my disclosure. I do some research with the pharmaceutical industry and also speak for and consult with their new drug development. So here are the objectives of tonight's discussion. So as for the theme of this year's Asian Oncology Society, we're looking at next generation sequencing and looking at actionable mutations. So we're gonna look at the safety and efficacy profile of current and emerging targeted therapy for liver cancer, and look at the last 10 to 20 years, how the treatment of hepatocellular cancer has evolved over the last 10 years. Look at the immunotherapeutic agents in the treatment of advanced hepatocellular carcinoma. After discussing some landscape of ACC, we're going to use the next generation sequencing and the foundation or carries or other somatic mutation testing, as well as the germline mutation testing in identifying the appropriate patients with hepatobiliary and pancreatic cancer. We're also going to integrate this clinical data and guideline recommendation into personalized decision about the optimal use of targeted and immunotherapy, and also look at the latest data on PARP inhibitor in advanced pancreatic cancer as well. So I've been doing this lecture over the last decade, and this was actually a figure I had back in 2010. And the liver cancer incidence in US has been doubling over the last few decades. And primary liver cancer mortality is rising pretty fast. So about 80 to 90% of liver malignancies are hepatocellular carcinoma, and about 10 to 15% of cases are biliary cancer. We seldom see the mixed type where you see both ACC as well as biliary cancer. Then you would have to treat what is the more aggressive type. So in 2010, about 24,000 cases of liver cancer was diagnosed yearly, and moving a decade in 2020, now we see about 42,000 to 43,000 cases every year. So it has almost doubled over the last 10, 12 years. The mortality has also significantly risen from 18,000 back in 2010 to about 30,000 cases in 2020. So as you can look at the incidence and the mortality, about 70 to 75% of liver cancer patients succumb to the disease. And this is just looking at the SEER data, how the incidence of cancer in the liver has been rising over the last 10 years. Here is a graphical presentation from up to date, looking what we're going to discuss. This is the liver, which is the bulk of our visceral organ. We're going to talk about some biliary cancer as well as pancreatic cancer. So let's look at hepatocellular carcinoma. I'm sure many of our hepatologists and gastroenterologists in the audience knows that is one of the most common primary liver malignancy. In US, we talked about 40,000 cases. Globally, there are about 1 million cases a year, so about 840,000 cases back in 2018, and mortality rate of about 782,000. So, you know, the mortality rate almost mimic the incidence of liver cancer. 90% of the cases are associated with liver disease, liver cirrhosis, and most people are asymptomatic. This is the major problem until they have advanced disease. And a lot of people with underlying liver disease can present with ascites and bleeding and abdominal pain. Most mortalities are caused by hepatic failure. And we can cure some of the select patients by liver resection and liver transplantation. So here is a diagram looking at what causes the injury. So any kind of toxins like alcohol, risk factors like hepatitis B and hepatitis C causes chronic liver injury, and your liver cells has to undergo proliferation and necrosis and apoptosis. And this multiple cycling of this chronic liver injury and liver disease causes liver cirrhosis. And with liver cirrhosis comes extensive scarring and abnormal liver nodules. And if you add that with genomic instability, it causes hepatocellular carcinoma. So as I have briefly mentioned, there are some curative, treatment options. So for single solitary liver mets or liver lesions or liver cancer, resection is a treatment of choice for non-cirrhotic ACC, but I have mentioned that majority of these patients have underlying liver disease. If you meet the Milan criteria, single lesion less than 5 centimeters or 3 lesions up to 3 centimeters, you can consider liver transplantation. But in places like New York, the waiting period is more than 12 to 18 months. So you need some kind of bridging therapy, and there are RFA, microwave, chemical, as well as SBRT, which can be used as a local regional therapy in this patient setting. Unfortunately, even with a curative intent, some of them will relapse with metastatic or advanced disease. And some people can present with systemic lung metastasis, bone metastasis, and other metastases with advanced disease. So today we're going to cover mainly the more advanced disease. And the systemic treatment options for liver cancer has been very limited. So this is one of my patients who has multifocal ACC. And this is arterially enhancing, but unfortunately I cannot show you all the CAT scan images of this patient, but this is just showing that, some patients like this may undergo liver resection. However, if they have MRI and other more delicate studies, you might see more metastatic disease in this type of patients. So in more advanced liver cancer, the systemic treatment options includes chemotherapy, but older drugs like doxorubicin and other chemotherapy was not very effective until 2007, when the SHARP trial was conducted in patients with advanced ACC, randomized to this multikinase inhibitor sorafenib versus placebo. Sorafenib produced a clinically meaningful delay in progression and overall survival. So the overall survival improved from 7.9 months to 10.7 months with a hazard ratio of 0.69. And since 2007, FDA has approved the use of sorafenib in unresectable ACC in US and other countries around the world. So this is the Kaplan-Meier curve showing the benefit of sorafenib, hazard ratio 0.69, so 31% risk of reduction for death if you get sorafenib compared to placebo. since sorafenib was a multi-kinase inhibitor, a lot of other companies and other pharmaceutical industries realized that their drugs could also be effective in liver cancer. And globally, there are 1 million patients. So people were very interested in drug development for liver cancer. Here in this diagram shows you a lot of failed negative phase 3 studies like brivenib, lenifinib, sunitinib, which is another drug approved for renal cell carcinoma, was also considered. Other drugs like everolimus, doxorubicin, tivantinib, and other second-line treatment options were all negative. So over 10 years, since 2007, a lot of negative studies were appearing in our ASCO meetings and other international meetings. However, we have seen some positive results, and we're going to discuss about those positive results in the next few slides. So one of the drugs that just got approved in the US was a drug called lenvatinib. This is an oral tyrosine kinase inhibitor, just like sorafenib, but blocks PDGFR, VEGF receptor 2 and 3, and FGFR receptor 1 to 3. So this shows you how it blocks the RAS-RAF-MEK kinase pathway, decreases oncogenic proliferation, angiogenesis. It also shows you downstream pathway of the PI3 kinase, AKT-mTOR pathway as well. So Dr. Finn showed this slides in lenvatinib, and lenvatinib is approved in the treatment of thyroid cancer. So this was an international study, which is called the REFLECT study, to look at the frontline lenvatinib versus sorafenib in phase 3 clinical trials. So patients with unresectable, untreated ACC was randomized to lenvatinib. And this was interestingly weight-based. A lot of times in oncology, we just have a flat dose. But people less than 60 kilograms, most likely in Asia, were given 8 milligrams per day. In Europe and Western world, it's usually more than 60 kilograms, so they were given 12 milligrams per day. And the standard dose of sorafenib, 400 milligrams BID. So this was stratified compared to East and West. It had both the superiority as well as the non-inferiority study design, and the primary endpoint was overall survival. So this was a global study with more than 154 sites. And one of the weaknesses about the ACC is that it's a diagnosis where you don't need a pathology or histology. So if you have an imaging or radiological criteria, this was enough to get people enrolled in this clinical trial. So some interesting thing about the study was that about 67% of the patient population was Asian, and that it was well balanced in both the demographic and underlying liver diseases. So this is the Kaplan-Meier curve showing, comparing lenvatinib versus sorafenib. And lenvatinib had median overall survival of 13.6 months compared to sorafenib of 12.3 months. Although the overall survival numerically was superior to sorafenib, the hazard ratio here was 0.92, and it crossed the boundary of 1. So although numerically better, statistically it was not superior to sorafenib. However, 13.6 months is definitely non-inferior to sorafenib. So based on this study, and because the secondary endpoint showed higher response rate, higher disease control rate, and better progression-free survival, lenvatinib got approved in the treatment of a first-line setting for patients with advanced liver cancer. The adverse event profile was very similar to other tyrosine kinase and previous treatment. Hypertension was slightly more with lenvatinib. Diarrhea and hand-foot syndrome was slightly more with sorafenib arm. And here is the EORTC quality life showing that lenvatinib is very well tolerated compared to sorafenib. So this large international study showed that lenvatinib is associated with non-inferior overall survival, but 13.6 months is pretty significant at this time compared to sorafenib. Had improvement in progression-free survival as well as other response rate endpoint. and higher patient-reported quality of life. So in 2018, the lenvatinib got approved as a first-line treatment of the US and kind of has taken up to be the standard treatment option, more commonly used in US than sorafenib since 2018. So what do we do when patients both get either sorafenib or lenvatinib and progresses on the first-line treatment? So here is a patient with liver cancer. After, let's say, 6 months, patient was doing well and then has more progressive disease. So there were recently multiple tyrosine kinase as well as the immunotherapy or immune checkpoint inhibitors that got approved in the US. One is a drug called regorafenib, which is approved in the treatment of colorectal cancer. But in this resource study, they look at patients who has documented ACC, progress on sorafenib, and look at regorafenib at 160 milligrams daily, 3 weeks on, 1 week off schedule compared to placebo. And this study was conducted between 2014 to 17. So there were no other effective agents at that time. So placebo was a reasonable option. So this is a Kaplan-Meier curve showing that the median overall survival improved to 10.6 months compared to 7 months. And the hazard ratio here was 0.63. So there was 37% risk reduction with the risk of death compared to placebo. So based on these findings, Stivarga was approved in the second-line treatment of liver cancer. So what are some common side effects? Regorafenib is a little more potent than sorafenib combination. So higher hand-foot syndrome, diarrhea, fatigue, and fatigue could be really a side effect or adverse event that can really affect the quality of life of our patients. So in my practice, most of them start at 80 or 120 milligrams, just like in the colorectal, and I try to dose increase if they can tolerate it better. So the side effects or adverse events were similar to sorafenib, but at higher frequency, and this has become a second-line treatment option in 2017. So the FDA-approved dosing is 160 milligrams per day, 3 weeks on, 1 week off cycle, but dose escalation from lower doses should be considered, and this should be avoided in child PBNC patient population. So another similar drug, cabozantinib, is approved in second-line setting based on Celestial phase 3 study. Here, the median overall survival improved from 8 months to 10.2. Hazard rate here was 0.76. The only caveat with the cabozantinib was that this included both second-line and third-line treatment options. So this was a slightly sicker patient population. Another drug that got approved in the second-line setting is a drug called ramucirumab based on the REACH2 study. But this was a biomarker-driven study, so only people with alpha-fetoprotein above 400 were included in the patients. And this showed the Kaplan-Meier curve, the benefit of ramucirumab compared to placebo. And some of the adverse events with ramucirumab is well known, fatigue, edema, hypertension, but generally ramucirumab is well tolerated. So these were kind of how patients were treated in ACC until 2020. You have TK options, tyrosine kinase inhibitors, but immunotherapy was kind of inching into liver cancer space. So we know that ACC is a classically inflammation-induced tumor type induced by hepatitis B and C, most common viral type of risk factors. Spontaneous immune responses were seldom observed. And then the immunomodulators were relatively hepatically metabolized. The problem is that liver has a lot of food whenever you intake things. So liver is a tolerizing microenvironment. So we didn't know if immunotherapy would be effective in ACC. So here's a diagram of how we can approach cancer patients, oncolytic virus, tumor ablation. But most of the study pharmacologic development was inhibitor of PD-1 and PD-L1 pathways, or checkpoint inhibitors. So we know that nivolumab and pembrolizumab was the most important drugs that were investigated. Currently, they are looking at tremelimumab, which is a CTLA-4 antibody. And there are other agonists and different antibodies that block CD40, OX40, CD27, and CD28. Sorry. So one of the first studies was the Checkmate 40, looking at nivolumab in the advanced ACC. So this was in second line after sorafenib failure or intolerant patients. And based on this phase 1/2 study, they noted that about half of the patients benefit from, nivolumab therapy, and the adverse events are very well tolerated, and the objective response rate was 20%. But what was impressive was that the overall survival for this patient population was 13.2 months in this refractory setting. So response occurred early, and the duration of response was pretty prolonged. So based on this, FDA approved the nivolumab in the treatment of a second-line setting. It was acceleratively, approved by the FDA, and the recommended dosing of nivolumab was 240 milligrams every 2 weeks. And the newer dosing formula now say you can give, nivolumab at 480 milligrams every 4 weeks. If the patient has any problems, or during the COVID-19 pandemic, they don't want to come to your cancer center and the clinics. So this was based on hoping that the first-line study would be effective. Unfortunately, the Checkmate 459 study, which was the study of nivolumab versus sorafenib, didn't meet its primary endpoint. This study was first presented at ESMO by Dr. Yao and his colleagues. And this was a pretty anticipated study, but nivolumab as a first-line therapy compared to sorafenib. However, the median overall survival was pretty impressive with first-line nivolumab, 16.4 months, and sorafenib of 14.7 months. Overall response rate was also superior in the nivolumab arm compared to sorafenib. However, the primary endpoint of overall survival, nivolumab was not superior to sorafenib. So the study didn't meet its primary endpoint. So pembrolizumab was also evaluated in KEYNOTE-224. Response rate was impressive, 16%. Disease control rate was 61%. And the usual side effect of pembrolizumab, some pruritus, fatigue, hepatitis, and diarrhea. And just like nivolumab, which did a randomized phase 3 study in first-line setting, pembrolizumab conducted a large phase 3 study in the second-line setting. So this was presented by Dr. Finn last year. So these are patients with CHARPU-A, Barcelona stage B and C, and ECOG performance 0 to 1. And they were randomized 2-to-1 to pembrolizumab 200 milligrams every 3 weeks versus a placebo every 3 weeks. So here's the Kaplan-Meier curve. So in second-line setting, pembrolizumab had overall survival of 13.9 months, almost 14 months, which is pretty impressive. However, the placebo arm had 10.6 months in this patient population. So here the hazard ratio was 0.78. So chance of death and mortality was reduced by 22%, and p-value was 0.02. So in most instances, this would be a positive study, but there was some interim analysis done, and this study, the pre-specified p-value was 0.01. So although clinically pembrolizumab was beneficial, it didn't meet its statistical endpoint. So kind of interesting that you have a potentially positive study, but statistically a negative study. So pembrolizumab reduced the risk of death by 22%, and overall response was higher than placebo. And interestingly, FDA approved both pembrolizumab and nivolumab. So in US, we can use both of these immune checkpoint inhibitors. But after a large phase 3 study, both were negative. FDA has not withdrawn the clinical efficacy of these checkpoint inhibitors. So what happened in the first line setting? We just talked about the sorafenib versus nivolumab study. And Genentech did an interesting study with atezolizumab and bevacizumab combination. So there was a small phase 1 study, 29 patients, and among those patients who had evaluable patient population, response rate was impressive, and 62%, so FDA granted a breakthrough designation. And the Embrave 150 phase 3, multi-center randomized clinical trials were conducted with atezolizumab to first-line sorafenib. So this study was actually presented in ESMO Singapore or ESMO Asia last year. And Dr. Chung presented this data, and thanks to the organizers for sharing their slides. And this basically look at that we have talked over the last 20 minutes about the benefit of multi-kinase inhibitors like sorafenib and lenvatinib. And I also shown you the clinical benefits of pembrolizumab and nivolumab. So we know that both anti-PD-L1 and VEGF pathway is important for liver cancer. So based on the phase 1b study, they launched a large phase 3 clinical trial. So here is the study design, Embrave 150, looking at patients with locally advanced and metastatic liver cancer, no prior systemic therapy. We are randomized to different regions, performance status, macrovascular invasion, extrahepatic metastases, and baseline alpha-fetoprotein. And it was 2-to-1 randomization to atezolizumab, bevacizumab combination versus sorafenib. These were some of the patient characteristics, but I'm sure you guys can get all these slides later on, so I'm not going to belabor with. But about 40-50% Asian population and rest of the world was enrolled, mostly CHARPUA patient population. So that about hepatitis B is most common in Asia, so about 52%, and then actually here 49%, and hepatitis C in Western world is about 20%, and most of them are Barcelona stage C patient population. So here's the primary endpoint. So this is the first randomized clinical trial where the doublet or atezolizumab combination or the experimental arm beat sorafenib. So hazard ratio here was 0.58. So there is a 42% risk reduction when atezolizumab was given combination, compared to sorafenib. So here the median overall for sorafenib is impressive, 13.2 months compared to 10 months in the SHARP study. But that atezolizumab, the median overall survival was not reached. So PFS also improved significantly, as you can see here, 6.8 months compared to 4.3 months. So what are some safety concerns? As you can see, atezolizumab has some diarrhea, hypertension, abdominal pain, and proteinuria, but we all have used atezolizumab in our lung cancer patients and other diseases, and bevacizumab is used in colorectal cancer, GBM, and other diseases, and lung cancer. So people are pretty well experienced with adverse events of atezolizumab and bevacizumab. Sorafenib had more diarrhea, hand-foot syndrome, and fatigue as their grade 1 and 2 and grade 3-4 adverse events. Another nice thing was that this study looked at the patient-reported outcome, and as you can see, atezolizumab, bevacizumab had better quality of life report outcome compared to sorafenib. So this is what the authors concluded, that Embrave 150 statistically improved and clinically meaningful improvement in advanced liver cancer patients compared to sorafenib, with overall survival improvement with hazard ratio of 0.58, as well as PFS improvement of 0.59. So PFS and overall survival benefits were consistent across all subgroups, and the safety and tolerability of the profile of this doublet combination was in line with other individual component and underlying liver disease. So the authors concluded that this is a potential new standard option in 2020. And in US and other developed countries, atezolizumab, bevacizumab has really become one of the most commonly used standard option for advanced liver cancer who have not received prior systemic therapy. Some caveats: bevacizumab has a long half-life. So in patients with esophageal varices, I just had a patient who came with hemoptysis and lung metastasis. So these are the patients with active bleeding or has active coronary artery disease or CVS issues. It would be avoided in using bevacizumab. And those patients, I would use TKIs because of their shorter half-life. And of course, if they have any interstitial lung disease, where use of a PD-L1 inhibitor is also prohibited. So some caveats in using this combination is that you might want to do EGD to screen for patients with esophageal varices and make sure that they don't have underlying bleeding problems or coagulopathy. So other combination therapies are coming, lenvatinib and pembrolizumab, and this had an impressive overall response rate of 42% in the phase 1 setting, and recently reported in ASCO and ASCO GI with extended 100 patient, has a comparable response rate with improvement in clinical benefit. And the LIP2 study, which is a lenvatinib pembro combination compared to single agent, is being completed, and we are eagerly awaiting for the clinical trial results. So there are other emerging options coming in the treatment of ACC, but I will not go over all these combinations because that might be another topic for discussion in the future discussion. So in summary, the frontline options has emerged. Now we have atezo-bev combination as a frontline therapy. Sorafenib and lenvatinib can be considered, but in general patient population, I think the doublet has become the new standard of care. And that's really changing the landscape of ACC treatment because all the studies in the second line setting are sorafenib failures. So I think, if you go with a frontline atezo-bev combination, then do you use sorafenib, lenvatinib, or, cabozantinib in second line setting, and how do you use it? How do you use other checkpoint inhibitors and other, monoclonal antibodies? Are very interesting. So in conclusion, I think the arrival of the newer targeted agents and immunotherapy for ACC has increased treatment options for patients with advanced ACC. Combination therapies are now the future for advanced ACC, and that atezolizumab and bevacizumab is the doublet combination based on evidence-based approach, based on phase 3 clinical trials, and other combination data is coming. So all these treatment options will be well balanced with the potential safety and tolerability of advanced ACC patients. So in the second part of my talk, I'm going to talk about how we can use the next generation sequencing for treatment of pancreatic-biliary cancer. And I'm going to use two examples, one in biliary cancer and one pancreatic cancer, to illustrate how NGS can be used in advanced GI cancers. So this next generation sequencing or molecularly targeted drug therapy has really evolved over the last decade. So we usually think of cancer as a disease of anatomy. We said biliary cancer, pancreatic cancer, liver cancer. Now in 2020, we use molecular, biomarkers. So like in colorectal cancer, we just don't call colorectal cancer. We say KRAS wild type, NRAS, BRAF, mutations and things like that. Clinical trials were just done with academic places, but now we need collaborative and international efforts because some of these mutations are rare, incidences. So compared to about 400 clinical trials in targeted therapy, now there are more than 3,000 to 4,000 clinical trials in targeted drug therapy that's ongoing. And we had little knowledge of immunotherapies. Now we are rapidly adapting to immunotherapy. And we have to now comprehensive diagnostic assays. I personally use Foundation. Some of the slides are from Foundation 1 testing. And some people use Caris, some use Perthera. So there are different molecular typings you can do with a different patient population. So these are 4 types of ways genes can be altered. Here is the normal type. Here you have the increase in copy number. So this is like HER2/neu that's amplified. You can see more, amplification of HER2/neu. You can have, substitution here. Some of the molecular targets are substituted. You can have insertion and deletions, and then you can have, gene rearrangement, like the FGFR receptor, that's going to be rearranged. So here are some examples, like BRCA is a base substitution. So this is a common mutation in breast cancer, and we're going to talk about pancreatic cancer with the BRCA1 and 2 mutations, and how that causes genomic alteration and more susceptibility to DNA damage. Insertion and deletion is a common way. If you have oncogenic insertions, can cause problems. You have a deletion that causes tumor suppressor genes. And then we have the fusion genes like the NTRK and then FGFR receptors, and then have the copy number alterations that can happen. So one of the new things with 2020 is the available of liquid biopsy. So now we can test blood to find ctDNA and then use a liquid biopsy to detect if there is any next generation sequencing or there are somatic mutations present. So there are 20 to 40%, you might see nothing, but then you can see both false negative and false positive results. But in advanced cancer patient where biopsy might be difficult, liquid biopsy potentially provide these mutations and gene rearrangement and methylation processes. So I'm going to give a typical example of cholangiocarcinoma. This is slides from Dr. Tony Saab. This is a global distribution of cholangiocarcinoma, and as I said, that liver cancer is about 90% of liver malignancy, and about 10% are biliary cancer. And the chemotherapy like gemcitabine has been used, but GemCis has shown to be effective in the biliary cancer patients. So standard of care in first-line setting is GemCis. But chemotherapy is marginally effective. So can we target some of the genetic alterations? And FGFR overexpression is known in lung cancer, breast cancer, and bladder cancer. And FGFR2, overexpression is noted in gastric cancer and biliary cancer. So there could be an activating mutations, there could be an oncogenic fusion rearrangement, and FGFR2 oncogenic fusion is noted in cholangiocarcinoma. So agents in development are pemigatinib, infigratinib, futibatinib. The only thing is that this is a rare event because biliary cancer is rare, and this FGFR2, gene alteration happens in about 15 to 20% of biliary cancer patients. So we're going to look at pemigatinib in their recent clinical trial. As you can see, the response rate was impressive, 35%. Median overall survival was 21 months. And Arnold presented this in ESMO 2019. And as you can see in this plot, that a lot of patients are either responding or having stable disease with pemigatinib. And similar, efficacy was noted with infigratinib. So in the latest study that was published in Lancet in May, this study is looking at pemigatinib for previously treated locally advanced metastatic cholangiocarcinoma. And this was a phase 2 study with only about 107 patients. But since this was a rare tumor and there was no other effective agents, FDA approved pemigatinib for treatment of FGFR2 fusion and gene rearrangement. So as you can see, about 82% had disease control, and PFS was 6.9 months with median overall survival of 21 months. So we all know that in second-line setting in patients with biliary cancer, their life expectancy is less than 6 months. Here, if you can find this FGFR, fusion or rearrangement, your median survival is 20 months. So this just illustrates you how, doing the next generation sequencing for this rare type of biliary cancer and finding the right mutation or, gene rearrangement with the oncogenic potential and finding the right drug can really improve the patient's clinical outcome. So the second case I want to illustrate is in another disease, but based on that dramatic improvement in the clinical outcome of a biliary cancer. The biliary cancer precision therapy choice, or batch, is running all over globally, and this is a clinical trial looking at HER2 new amplification, PI3 kinase, DNA repair, BRAF mutations, and using atezolizumab as people with no actionable alteration. So these are multiple PIs where you might have a potential for benefit in this type of batch or basket trial. So one of the advantages of this kind of trial is that at least you don't just look for 5% of that mutation. You have other options that you can potentially go in, and having this no actionable alteration is very important because patients will be so disappointed that they will not have a match for their clinical trials. So hopefully this type of trials will be available for other GI cancers as well. So another example I wanted to give you was in pancreatic cancer, where BRCA mutation is a rare disease, but the PARP inhibitor olaparib as a maintenance treatment for first-line platinum-based chemotherapy in patients with germline BRCA mutation. So this was a major presentation at ASCO last year. And this is the slides from Dr. Kindler. Thanks for sharing this with us. And this shows you how many patients with metastatic pancreatic cancer is treated. Usually the standard of care is either FOLFIRINOX in young fit patient population, gemcitabine and nab-paclitaxel in patients with elderly, poor performance status. And your median PFS is about 6 months, and median overall survival is less than 12 months. Now, about 4 to 7% have BRCA1 or BRCA2 germline mutations, and these patients have increased benefit in platinum-based chemotherapy. And recent data has shown that, PARP inhibitors, because you have a double strand break and reliance on, homologous recombination repair and other DNA repair mechanism might be important in using olaparib as a maintenance therapy. So phase 2 study conducted shows some response rate and improvement in PFS that led to a large phase 3 clinical trials, as a maintenance strategy. So patient has to be on first-line chemotherapy for 4 months. And if they have either CR, PR, or stable disease, they get randomized to olaparib 300 milligram BID or placebo. So this is some patient characteristics. 57 is the median age. In my clinic, I see 75, 85-year-old with pancreatic cancer. So in clinical trials, you have 10, 15 years younger patient population. And this just show you that majority got FOLFIRINOX, some got cisplatin, and other chemotherapy. And this is the primary endpoint. Olaparib has median PFS of 7.4 months compared to 3.8 months in the placebo group, and the hazard ratio here was 0.53. So the risk of progression or death is reduced by 47%. So this is a pretty impressive results. And after this presentation, it was published in NEJM, and the NCCN, the National Cancer Network, recommended every pancreatic cancer patient should be checked for germline mutation because they are effective therapy using olaparib. Interestingly, the median overall survival was impressive, 18.9 months, but there was no difference between placebo and olaparib. So there are some, possible, questions and answers, and the discussion went into people getting olaparib after treatment progression, not in the study, but off study, as well as other, platinum-based therapy that's improving the outcome. So common adverse events were fatigue, nausea, diarrhea, and I have used this in some of my patients, and some people have really bad toxicities, fatigue and anorexia and abdominal pain, and actually some people complain that it might be even worse than chemotherapy. So in some patients, they are well tolerated, but in some patients, they have a significant toxicities. So as a maintenance strategy, it's an option, but you have to really consider all the adverse events and the clinical benefit in this patient population. So here is kind of the key takeaway in the the last two slides, two examples I have shown you, that everybody is so excited about cancer genomics and translational research. When you find actionable mutation and there is a targeted therapy, outcomes are amazing. I can tell you personally, we participated in the New York Genome Center project, and actually my first patient had pancreatic cancer with BRAF mutation, and that patient got BRAF inhibitor, and he failed 3 lines of chemotherapy, and after getting BRAF inhibitor, he had a pretty good, remarkable drop in his tumor markers, CAT scan showing response, and he did well for 6 months until his disease progressed and succumbed to the disease. So when you really find this type of actionable mutations, the outcomes can be amazing. However, finding this actionable mutation is very rare in most of the instances. So the next, pancreatic cancer patient I see the P53 mutation, KRAS mutation, and unless we find a new drug for KRAS, really there are very few pancreatic cancer patients who the treatment option is limited with targeted drug therapy. So they are all, given systemic chemotherapy. So I have given you 2 examples, pemigatinib for FGFR2 gene alteration in biliary cancer, olaparib in maintenance therapy for BRCA mutation advanced pancreatic cancer. So, hopefully more clinical trials, should be considered like a batch studies. And the cost of NGS and cost of all these targeted drugs could be pretty expensive. So if you are resource limited in the third world setting, this might be another critical issue. So tissue testing still remains the gold standard, but when not available, liquid biopsy can also be considered. So I think this concludes kind of my second portion of the talk on using NGS in biliary and pancreatic cancer. And I'll be happy to take any questions about GI oncology. This is my email, I have my cell phone. And thanks, and be safe.
Hello, everyone. Hello from Singapore. I'm Supin from Singapore. I'm a GI oncologist. And welcome to the Q&A session now. Before I start, I'd like to thank Dr. Fernando and the organizing committee for hosting this first virtual Asian Oncology Society meeting. It's such a pity that we can't be in Manila, where I have many very dear friends, and we can't spend some time together, but hopefully next time we'll meet again in person. So Dr. Choi Minsig, from all the way from the States, has just given a very comprehensive lecture on the changing landscape of hepato-biliary as well as pancreatic cancers. And now please feel free to ask questions to Dr. Choi. We have 5 minutes to discuss some questions that you may have. I'll start the ball rolling by asking Dr. Choi. Now that atezolizumab and bevacizumab is a new standard of care in the first-line setting, do you routinely, how would you select your patients for atezolizumab and bev versus using one of the existing TKIs like sorafenib or lenvatinib?
Good evening, everybody, and I think it's good morning in the US. Thanks for the kind invitation, and thanks everybody for joining this virtual conference. I'm sorry about the COVID pandemic, but because of that, I think now any national and international meetings are now virtual. So I listened to my lecture, which was presented a couple of months ago, but the treatment for ATC has now been very interesting because of so many new treatment options that has just been approved, and a lot of new studies have shown that both immuno-oncology drugs and anti-angiogenic agents are effective. And the IMbrave 150 study have shown that in a phase 3 setting, that the combination of atezo bevacizumab is superior to sorafenib, which has been the standard treatment for the last decade. So in most patients who's healthy, who has a good performance status, I think the atezo bevacizumab combination would be used in the first-line setting. As far as the TKIs are concerned, I usually reserve this for patients who has a poor performance status, patients who has underlying cardiovascular disease, and people who might not tolerate either bevacizumab or atezolizumab treatment options. One other caveat is that this bevacizumab has a long half-life, and in patients with liver disease or cirrhosis, or who has a high risk of a bleeding tendency, then you might want to avoid using atezo. But if you have a fit patient who's in good clinical condition, I think the combination is, I think, the first strategy to go in 2020.
Thank you. So there's a question from the audience about IO combinations with anti-angiogenics like the atezo-bev versus IO combinations with TKIs. Presumably, I guess, they are referring to pembrolizumab and lenvatinib combinations. Do you have any comments on this? Should we be using IO-TKI in the treatment of liver cancer at this point in time?
So we are actually one of the teams who joined the RIP2 study, which was the lenvatinib pembrolizumab. And I think the Mount Sinai group has shown the phase 1-2 study, the impressive response rate and the tolerability of lenvatinib pembro. And there are multiple studies going on, Rego, Nivo combinations, and other potential TKI immune checkpoint inhibitors. The only thing is that the response rate in phase 1-2 setting and the response rate in phase 3, just like in the EMBRAVE, the response rate and other PFS and overall survival changes from earlier clinical trials to phase 3 setting. So my recommendation at this point is you follow evidence-based approach, and the study for most of these studies are completed in the last 3 to 6 months. So hopefully in the next 6 months we'll have the outcome in the phase 3 setting in this TKI immune checkpoint combinations. But at this setting, I'll still go with atezolizumab because there is a published, phase 3 study in this setting. But in some patients who might not be able to tolerate it, you might consider those TKI combination, but I'll go with evidence-based approach at this time.
Thank you very much, Dr. Choi. I don't think we have any more time for any more questions. Thank you, everyone, for joining us in this session. And please keep safe, everyone.
Yeah, thanks, everybody. And thanks, everybody, for sharing their slides and information with me. And take care.